So the next question was true about optic neuritis. The options were multiple myeloma is a cause, oral corticosteroids are the drug of choice, there is no pain with ocular movement, and relative afferent pupillary defect. So let's see all the options one by one. Before we go to the answer, what is actually a optic neuritis? Now, you can basically understand the optic neuritis as the term itis always means inflammation. You can see this picture, and in this picture you can see that there is a swollen optic nerve head. Okay, so there is a swollen optic nerve head, so I call it optic neuritis. So per se optic neuritis can have three basic types. The first one is when there is the involvement of only the optic nerve. I call it, there is a papillitis. So there is a optic nerve head which we see during a fundus examination that is involved. We call it papillitis. The second one is that when we have the inflammation of the optic nerve which is basically beyond the optic nerve head. So this area which I am basically pointing out here is, this is basically the retrobulbar part of the optic nerve. So this is called retrobulbar neuritis. Now, why retrobulbar neuritis is important to understand? Because in these cases, your optic nerve would be basically seen normal from the fundus examination, but still the patient would have the features of optic neuritis. The third one is basically the condition where the optic nerve head is involved, as well as we have the involvement of the nearby retina. So your retinal nerve fiber layer is also involved. So this is basically called a condition which is neuroretinitis. Now the most common cause of either papillitis or retrobulbar neuritis or neuroretinitis in a young adult is multiple sclerosis. So it is not multiple myeloma, it is multiple sclerosis. And as if you are having a patient of a retrobulbar neuritis, sometimes the superior rectus fibers are basically attached to the optic nerve head sheath. Okay, so because there is an inflammation of the optic nerve, so there can be pain on the eye movement. Now, what is the treatment of these patients? Now, the treatment of these patients is not the oral steroids. You have to give intravenous methylprednisolone. So, you give intravenous methylprednisolone for 3 days, and after giving intravenous methylprednisolone for 3 days, then you can give a 11-day course of the corticosteroid. Okay, so the drug of choice is not the oral steroids but the intravenous methylprednisolone. Whenever you see a patient of optic neuritis, the first sign that you see is the decrease in the contrast sensitivity as well as the color vision. So let's talk about the clinical features of the optic neuritis. So the first thing is that the patient's color vision and contrast sensitivity, they are affected. Then the second feature that happens in the patients of optic neuritis is relative afferent pupillary defect. So when we basically, let's say if there is a left eye optic neuritis, so when we basically put the light on the normal eye, this constricts, but the other eye, which usually should have been constricted because of the consensual reflex, instead of constriction it is dilating. So this is called a relative afferent pupillary defect. And as I told you, there can be patients who are having a pain on the eye movement, and in later stages decrease in vision as well. There may be sometimes field defects like central scotomas or centrocecal scotomas in these patients. Okay, so these are the major clinical features of a patient of optic neuritis. Okay, so let's see that what our question has asked and then we would answer the question. So our question was true about optic neuritis. So multiple myeloma is a cause. So it is not the multiple myeloma, it is the multiple sclerosis as we have basically discussed. It is not the oral corticosteroids that we give in these patients. What we give is the intravenous steroids. Okay, so intravenous methylprednisolone is given, and nowadays it is not only just intravenous methylprednisolone. Sometimes we are using dexamethasone intravenous as well, but definitely oral is not the first choice. Oral is basically given after the 3 doses of intravenous methylprednisolone. So there is no pain in the ocular movement. This is also wrong because there can be pain in the ocular movement, and more commonly this is happening when the patient is having a retrobulbar neuritis. In that cases, the pain on the eye movement is quite diagnostic because your optic nerve head appearance seems to be basically normal. Relative afferent pupillary defect is absolutely present in the optic neuritis. So D is the answer of choice here. So the next question was not an optic nerve head sign in glaucoma. The options were bayoneting sign, bearing of blood vessels, Rene's nasal step, or increased cup disc ratio. Now, one thing to note in this question is that all of these are basically seen in glaucoma. We have to tell them that which of the following is not a optic nerve head sign. Okay, so let's see all the options one by one. So first option was bayoneting sign. Now what is bayoneting sign? Bayoneting sign basically means that when you have a patient with glaucoma at the level of optic nerve head, there are blood vessels which are taking a turn from the cup margin. Okay, so you can see that the blood vessels are basically taking the turn at the cup margin very abruptly. This is basically called bayoneting sign. So it is the optic nerve head sign. So second sign is bearing of blood vessels. Now what happens in bearing of blood vessels is that the blood vessels usually are not seen crossing the cup. But in the cases of glaucoma, because of increased intraocular pressure, there is a basically excavation of cup and you can see the blood vessels there. This is called bearing of blood vessels. So this is also an optic nerve head sign. Then we have the Rene's nasal step. Now what is the meaning of Rene's nasal step? Now, when we have a visual field, in some cases we can have advanced visual field defects like this, which is called a Jerem's double arcuate scotomas. So what happens in Jerem's double arcuate scotoma is we have a arcuate scotoma in the superior half as well as inferior half. Now, whenever these arcuate scotomas are there, they basically respect the horizontal midline raphe. Okay, so this is the horizontal meridian, and if you can see here, okay, so these are the two meridians, these are the two arcuate scotomas. So this area, this is like a horizontal step, okay, and this is called Rene's nasal step. So Rene's nasal step is basically a visual field finding and it is not basically a finding of a optic nerve head. So answer here would be C, that is Rene's nasal step. Okay, increased cup disc ratio is also very easily you can understand that is a optic nerve head sign because normally the optic nerve head CD ratio is around uh, 0.3 is to 1, 2.5 is to 1. But in cases of glaucoma, that increases and the cup size increases, so you would have increased cup disc ratio. Okay, so the answer here would be C. So this was the next question. The question was a patient with animal tail trauma presented with the following feature. What is this feature called? So basically they were asking about this feature. So if you can see in this picture that this patient is having a pus in the anterior chamber. Okay, so this pus in the anterior chamber is basically called hypopaeon. Okay, so this is a characteristic feature which can be seen in the patients of endophthalmitis. It can be seen also in the patients of corneal ulcer, and specifically in the cases of fungal corneal ulcer, where you are getting a history here of animal tail trauma. So if there is a fungal corneal ulcer, so in that cases you have a thick hypopion and a convex hypopion. You can see here there is a convex shaped hypopion. Okay, so the answer here would be B. Now, what is hyphema? Hyphema is basically blood in the anterior chamber. So, in the cases, let's say there is a blunt trauma or there is an intraocular surgery, you can have a hyphema as well, but there would be a red blood colored deposition in the inferior half. Aqueous flare is basically seen in the patients who are having a uveitis. So, you may be having the cells, pigments, and proteinaceous particles in the anterior chamber. That is basically called aqueous flare. So aqueous flare is basically the characteristic feature of your uveitis. And then we have glaucoma flecken. Now glaucoma flecken is nothing, it is just pigment dispersal on the anterior capsule of the lens. So whenever you see pigment dispersal on the anterior capsule of the lens, then this means that this patient has a previous history of a acute angle closure attack. Okay, so in that cases you would see glaucoma flecken. So the answer here would be B.
So next question was, a 10-year-old boy with intentional tremors, hepatomegaly and CNS changes came to the OPD with the following image. The image of the cornea was being shown with a greenish hue over the limbus. Siblings also have the same disease. What can be the potential diagnosis? So from this you can see the ocular image shows that there is a KF ring, and with the KF ring you know that the answer here is Wilson's disease, and you can see the hepatic symptoms as well as the neurological changes are also there in the patient. So definitely the answer here is Wilson's disease. Okay, let's have some words regarding the KF ring. Now KF ring, as you know, is seen in the Wilson's disease. Though it is not only seen in the Wilson's disease, it can be there in the patients of neonatal cholangitis as well. Now, Wilson's disease has been asked again and again in the exam. So please do your KF ring and ocular parameters or ocular manifestations of systemic disease very well. Okay, so now we know that the KF ring is basically seen as a greenish ring around the limbus. Okay, so you have greenish ring around the limbus, and slit lamp is very useful when we are basically examining this patient, because on the naked eye you may basically miss it also. So it is what it is. It is, as we know, copper deposition. In which layer of the cornea? It is there in the Descemet membrane. Okay, so you can basically remember it with the mnemonic KFC delivery. Okay, the famous chicken KFC chain. So KF ring, copper deposition in Descemet's membrane. That is how you can remember the Wilson's disease and the KF ring. Now remember, this is a reversible ring. So after the treatment with the penicillamine, in many of the patients you would have a KF ring that can disappear as well. Okay, and it is there in 50% of the patients having hepatic symptoms, and almost 90% to 100% of the patients having neuropsychiatric symptoms. So it is not very much specific for those patients who have hepatic involvement, but very specific in those patients who have neuropsychiatric involvement. So these are some important points you should be remembering regarding the KF ring and the Wilson's disease. Another type of cataract they are also asking that can happen in Wilson's disease, and that is called a sunflower cataract.
So friends, today we would talk about the Snellen's chart and various questions that can be asked from the Snellen's chart. So what we have seen in last 2 years is that both AIMS as well as your Neetpg as well as even in the foreign medical graduate examination Fmge, you get questions from the Snellen's chart. So what is actually a Snellen's chart? It is something through which you can tell about the visual acuity of the patient. Okay. So normally what we have in a Snellen's chart is we have a topmost letter. Okay. We call it 6 by 60, and then as we go down the size of the letter decreases. If you can see, then we have H, D, P, U. So what you are seeing is that the size of the letter is decreasing. So you can say this is 6 by 60, followed by 6 by 36, 6 by 24, 6 by 18, followed by 6 by 12, 6 by 9, and the best visual acuity which the human is basically considered is 6 by 6. So this is the visual acuity chart, which is we call as Snellen's chart. So how we do this? We basically make the patient sit in a room and we cover one eye. This is the trial frame. Okay, this is the trial frame which we have basically put. So we cover the eye, and after covering one of the eye, we tell the patient to look at a Snellen's chart and basically read there. So initially he reads without any correction, and then we give a pinhole. So with the pinhole we try to basically neutralize the refractive errors. One more question which is asked from the pinhole is that what is the diameter of the pinhole? So it is 1 millimeter. So the question that was asked was that angle subtended by the letter of Snellen's chart, that is at 6 by 6 at 6 meter of distance. So let's say this is the 6 by 60 and this one is 6 by 6. So this letter, let's say this letter P, so what this would subtend at an angle, what is the angle it subtends at 6 meter of the distance? This was the question. Now how basically we can answer these types of question? So as you can see, these letters, these are called optotypes. So this optotype is made in a way that it fits into a 5 by 5 square. Okay, so this is a 5 by 5 square. Okay, so all the letters E, H, D, so everyone is made like this, that they fit into a 5 by 5 square. So this 5 by 5 square here, let's say this is the angle P, letter P. So it is like this. So this 6 by 6, what is the angle subtended at 6 meter of distance? This was the question. Now before basically I go to what the various angles are, let's understand what is the meaning of 6 by 60. What is the meaning of 6 by 6? So 6 by 60 means that our patient can read this letter at 6 meter of distance, but a patient with the normal visual acuity can read this even at 60 meter distance. Okay, so this is P oblique N. So P is our patient's visual acuity and N is a visual acuity of a normal adult. Okay, so similarly if we say this is 6 by 36, what it actually means is that our patient basically can read it from 6 meter distance. He has to come very close, but our normal person can read this even at a 36 meter distance. So when we go to 6 by 9, this means that our patient can read this at 6 meter, but a normal person can basically read it even at 9 meter distance. Okay, so 6 by 60 is the worst visual acuity as compared to 6 by 6. Okay, and this whole square, this would subtend an angle of 5 minute of arc. Remember, it is 5 minute, not 5 degree. This is 5 minute of arc that it would subtend at 6 meter. So one more question that can be asked similarly is that what is the minimum angle of resolution? Minimum angle of resolution. For minimum angle of resolution, it means that what is the basically the visual acuity of a patient where it can basically differentiate between two lines. Okay, so let's say we have two lines very close to each other. How much should be the distance between the angular distance between them, so that we can basically say that these are two different lines and they are not one single line. So this is 1 minute of arc. Okay, and this was also a previous year question. So this is a 1 minute of arc, and the 5 minute of arc is the distance, the angular distance which the smallest letter would basically subtend at 6 meter. Okay, now similarly, how they can ask a question? They can ask a question, let's say you have a 6 by 60. So this 6 by 60, what is the angle that it would basically subtend at 6 meter? This can be also potential question. So 6 by 60 is the largest letter and 6 by 6 is the smallest letter. How much is this letter basically, how many times this letter is from the smallest letter? Okay, so this is 10 times. So the angle that it would make, that would be 5 into 10, that means 50 minute of arc. Similarly, if they ask what is the angle subtended by 6 by 36, so this is 6 times. Okay, 6 into 6, that is 6 times. So then it would be 5 into 6, that is 30 minutes of arc. Similarly, if they ask 6 by 12, so this is 2 times. So the angle subtended would be 5 into 2, that is 10 minute of arc. So that is how you can basically answer the questions which are asked on the basis of Snellen's chart. Hope you would basically understand this, and if you have any doubts you can write in the comment section, and if you have any questions you can also ask me.
So next question was a 10-year-old boy with intentional tremors, hepatomegaly and CNS changes came to the OPD with the following image. The image of the cornea was being shown with a greenish hue over the limbus. Siblings also have the same disease. What can be the potential diagnosis? So from this you can see the ocular image shows that there is a KF ring, and with the KF ring you know that the answer here is Wilson's disease, and you can see the hepatic symptoms as well as the neurological changes are also there in the patient. So definitely the answer here is Wilson's disease. Okay, let's have some words regarding the KF ring. Now KF ring, as you know, is seen in the Wilson's disease. Though it is not only seen in the Wilson's disease, it can be there in the patients of neonatal cholangitis as well. Now, Wilson's disease has been asked again and again in the exam. So please do your KF ring and ocular parameters or ocular manifestations of systemic disease very well. Okay, so now we know that the KF ring is basically seen as a greenish ring around the limbus. Okay, so you have greenish ring around the limbus, and slit lamp is very useful when we are basically examining this patient, because on the naked eye you may basically miss it also. So it is what it is. It is, as we know, copper deposition. In which layer of the cornea? It is there in the Descemet membrane. Okay, so you can basically remember it with the mnemonic KFC delivery. Okay, the famous chicken KFC chain. So KF ring, copper deposition in Descemet's membrane. That is how you can remember the Wilson's disease and the KF ring. Now remember, this is a reversible ring. So after the treatment with the penicillamine, in many of the patients you would have a KF ring that can disappear as well. Okay, and it is there in 50% of the patients having hepatic symptoms, and almost 90% to 100% of the patients having neuropsychiatric symptoms. So it is not very much specific for those patients who have hepatic involvement, but very specific in those patients who have neuropsychiatric involvement. So these are some important points you should be remembering regarding the KF ring and the Wilson's disease. Another type of cataract they are also asking that can happen in Wilson's disease, and that is called a sunflower cataract.
So the question was incorrect statement regarding the pathology as shown in the figure. As you can see, there is a growth over the cornea which is being attached near the center of the pupil. This vascularized growth, what we call this? We call this pterygium. So the diagnosis here is that the patient is having pterygium. Now let's see the options. So the option one is progressive and regressive type. So definitely this is a true. We have two types of pterygium. One which is basically increasing and progressively basically having a encroachment over the cornea and increasing in size, that is called a progressive pterygium. The one which is stationary and which is atrophic, that is called a regressive pterygium. Then it consists of head, neck and body. Definitely these are correct. We have the various portions. This one is the head, neck and the base, which is the body. So elastotic degeneration of the collagen, definitely this is also a correct statement. This is a degenerative elastotic degeneration and proliferation of the vascularized granular tissue over the cornea. That is the basic definition of pterygium. Surgical excision reduces the chances of recurrence by the 90 to 99.5%. Now, this is basically a wrong statement. Okay, this is a wrong statement. This is basically that most of the times, if you just do a excision without any additional procedure, the chances are that the 80% of the times it recurs. This was a previous year question as well. So the answer here would be D. Let's discuss about the topic of pterygium. Now, when we talk about the cornea, cornea is a transparent avascular structure. So, when if there is a fleshy outgrowth over the cornea that has the granulation tissue and the vascular tissue, this is basically called the pterygium. So, what is pterygium? It is wing-shaped fold of conjunctiva over the cornea. Now, the most common quadrant where you get a pterygium, that is the nasal quadrant. This was also a previous year question. Okay, so let's talk about the pathology of the pterygium. What is pterygium? It is basically the elastotic degeneration, okay, and proliferation of vascularized, very important, granular tissue. It is vascularized granular tissue, please remember this, over cornea. Okay, and it is basically a connective tissue degeneration. Now, more commonly, if we talk about the epidemiology, it is seen in the tropical climates where the patients are basically being exposed to the UV radiation. So we can say that the UV radiation may be there as a pathogenesis. So because it is seen in the tropical climates and mostly in those patients which are basically exposed to the outside work, so we also call it as a surfer's eye. Okay, now if we talk about the classification, we have the progressive and atrophic type of pterygium. The progressive one is the one which is basically increasing in size, and the corneal opacity is associated with active vascularized tissue encroaching the cornea. Now, in the atrophic one, it is basically, or I also call it regressive pterygium. This is stationary, okay, and it is not increasing with the size and have very fine vessels and the fibrosis. Okay, if we talk about the various parts of the pterygium, we basically classify it into three parts. We have the one which is the head, which is over the cornea. Then we have its neck. Now this neck is at the level of limbus, and the main body, which is over the sclera. Okay, so whenever we have to remove it, we have to remove not only whole of the pterygium, we also have to remove a small area which is the normal conjunctiva also with it. Okay, so this technique where we remove the head, neck and the body, this is basically called a surgical excision. The problem with the surgical excision is that it has around 80% recurrence level. So to decrease the recurrence, what we do is, when we remove the normal conjunctiva, we take a part of the normal conjunctiva and put it over the bare sclera. Okay, so this is called allograft. Okay, you can take it from the other eye, or you can basically take it from the same eye, then it is called a autograft. Okay, we can do any one of them. Then you can use antimitotics like mitomycin C, 5-fluorouracil. Also you can basically go with the irradiation, though these two are more of a theoretical importance, not basically done in the clinical settings. So these are the various important points that you have to remember regarding the pterygium. Now one more question which was asked few years back was that sometimes there is a iron deposition line which you can basically see over the pterygium, and this iron deposition line over the pterygium is called Stocker's line. So the next question was, topical atropine is used in all of the following conditions except. Your options were malignant glaucoma, corneal ulcer, acute congestive glaucoma and anterior uveitis. So we all know that the atropine is a very important class of drug which is used in many ophthalmic disorders. It can be used in malignant glaucoma. Why? Because it gives rest to the ciliary body. Okay, that is so important that it gives rest to the ciliary body, so that any ciliary spasm which is basically causing the malrotation of the ciliary body towards the posterior side, it can basically help it there. So yes, atropine can be used in the patients of malignant glaucoma. Then we have the corneal ulcer, where it is used in basically giving the rest to the ciliary body, as I told you in malignant glaucoma. So it decreases the pain, and in any patient of corneal ulcer where there is an anterior uveitis as well, it would basically help in preventing the formation of posterior synechias. Also, it gives basically the rest to the ciliary body and decreases the exudation from the capillaries, and also helps in draining the waste products out from the eye. So in the same condition, it can be used in the patients of uveitis, and it is a very integral part of the treatment of uveitis. Remember, The drug of choice in the patients of uveitis is always steroid. Now we come to the answer of this question, that is acute congestive glaucoma, which is basically a type of acute angle closure glaucoma. So we know because there is an angle closure, so we basically do not use atropine here, we use pilocarpine here. Okay, so the atropine is not used in the patients of acute congestive glaucoma. The one drug which is used is basically helps in the opening of the angles, that is the pilocarpine. Okay, so the answer here would be C. So the next question was most common cause of blindness in India according to the 2015 to 2019 survey. So the answer here is always cataract. There is no doubt about that. Now the controversy was that they have not asked about the blindness, they have asked about the visual impairment. Now if they would have asked about the visual impairment, then the answer would have been refractive error. Okay, so what is the difference between the blindness and the visual impairment? So blindness means that anything which is less than 3 by 60, as I told you, and visual impairment means that anything which is less than 6 by 18. Okay, so that's why the answer here would be A, that is the untreated cataract. So what is the definition of blindness in India? So earlier the definition was different, but you must be knowing the new changes in the definition of blindness in the National Program for Control of Blindness and Visual Impairment, that we call as NPCBVI, as I told you. So here now the blindness definition according to the WHO as well as in India is both anything vision less than 3 by 60 in the better eye. Now what I mean by better eye here, let's say I have one eye vision that is 2 by 60 and other eye vision that is 6 by 60. So what is my better eye? My better eye is having a vision of 6 by 60, so it does not come under the cloud of the blindness. Now if I have vision 1 by 60 in my right eye and 2 by 60 in my left eye, my better eye is my left eye that is having a 2 by 60 vision. So I am practically blind because my better eye has vision less than 3 by 60. Now it is only not the vision, it is also the visual field in the criteria. So sometimes the vision may be even 6 by 6, but the patient would be blind because there would be less than 10 degree of the central vision that is present. So if there is a less than 10 degree of the central field in a patient, even if he has a vision which is more than 3 by 60, then also he comes under the preview of blindness. Remember, if they ask about visual impairment, then the criteria is less than 6 by 18. Now let's see what are the various causes of blindness in India. What are the major causes? So remember, the major causes are cataract. Now I am talking about the causes of blindness, which is around 63%, followed by refractive errors, followed by glaucoma, any posterior segment disorders like your diabetic retinopathy, corneal blindness, and last but not the least, surgical complications. Okay, so there are lots of causes. These are the ones which are the most common causes of blindness. So out of them, the cataract is the most common, followed by refractive errors and glaucoma, that you have to remember. And also please remember that there is a difference between the criteria of blindness as well as the visual impairment. Blindness is less than 3 by 60, visual impairment is less than 6 by 18. Then we have some conditions which also can be asked in the exam, that is, what is economical blindness? So economical blindness is basically defined that when the vision is in the better eye. So remember, whatever I am telling is the vision in the better eye is between 6 by 60 to 3 by 60. When it comes to the social blindness, then it is anything which is the vision between 3 by 60 to 1 by 60. Then we have the legal blindness. So legal blindness is anything when the vision is between 1 by 60 to PL positive. PL positive means that you basically tell the patient that is the light coming in their eyes. So he says yes, but if you see the hands moving in front of the eye, he cannot basically identify this. This is called PL, that is the perception of the light positive. And then we have total blindness. Total blindness is defined as vision which is no perception of light. Okay, so these are also few terms which have been asked, so please remember them also.
Let's talk about the next question. The question was not true regarding the complicated cataract. Your options were Krukenberg spindles, polychromatic luster, breadcrumb appearance, and seen in chorioretinitis. Now, do not confuse the complicated cataract term with another term which is after cataract. Some students ask me, sir, what is the difference? So, after cataract is something which we see after a cataract surgery. Okay, like we see posterior capsular opacification. Now let's see what is complicated cataract. So complicated cataract is a cataract which is after the intraocular condition. Let's say there is a patient who has got a retinitis pigmentosa, who is having uveitis, who is having a chorioretinitis. So in these conditions, if the patient develops a cataract, this is called a complicated cataract. The basic features of these patients are that in your cataract you get various colors of opacities, and this is called polychromatic luster. Okay, also called breadcrumb appearance. You can get it from our notes. Breadcrumb appearance. This is the basic feature of a patient with the complicated cataract. Now do not confuse Krukenberg spindles. So the answer here is Krukenberg spindles, where you get the spindle like pigment dispersion in the corneal endothelium. So Krukenberg spindles, as I told you, is basically the feature of pseudoexfoliation syndrome. It can be in the patients of pigment dispersion syndrome. It can be in the patients of trauma. Okay, so the answer here would be A, that is Krukenberg spindles.
So the question that is asked is, which of the following drugs increase the trabecular outflow? So as I told you when we started our discussion on the various type of pharmacotherapy of glaucoma, I told you that it can either basically increase the trabecular meshwork outflow, it can basically increase the uveoscleral outflow, or it can basically decrease the aqueous production. That is how the various types of the anti-glaucoma drugs basically can decrease the intraocular pressure. So in this question, what should be the answer? So our options were timolol. So we know that the timolol basically decreases the aqueous production. Acetazolamide, the same thing, it decreases the aqueous production. Brimonidine, it has the triphasic action that I told you, and that is the new drug, that is netarstrudel. So this new drug, the netarstrudel, this is basically a Rho kinase inhibitor, and Rho kinase inhibitor act as decreasing the intraocular pressure by increasing the trabecular meshwork outflow. So let's study about this new class of drugs in the anti-glaucoma section, which is Rho kinase inhibitors. They have basically two types: the netarsodil, which is OD dosage, and repasodil, which is the BD dosage. Rho kinase inhibitors basically have the mechanism of action by increasing the trabecular meshwork outflow. Very, very important this year question. Then it has been also seen that this Rho kinase inhibitors, they have the neuroprotective action over the ganglion cells, as well as they have the corneal endothelial protection activity as well. So these are the major ways through which Rho kinase inhibitors work. The most important that you have to remember is increasing the trabecular meshwork outflow. Now the problem with the Rho kinase inhibitors is that its undesirable side effects. As you can see in this picture, you can see the various deposits in the subepithelial like this. So in the subepithelial layer, you have drug deposits like this. Usually they do not interfere with the vision and they are called vortex keratopathy, or I also call it as cornea verticillata, another previous year question. The most common side effect of the Rho kinase inhibitors is the redness they basically do, that is the hyperemia. And we have sometimes seen that in cornea you can have opacities like this also, which is called honeycomb pattern of opacities in the cornea. So these are the usual undesirable side effects of the Rho kinase inhibitors.